Good evening, good morning, good afternoon, wherever you are in the world, and welcome to the third happy hour at the Sports and Exercise Medicine Research Centre at Trobe University. I hope you are all got your beverage of choice, your questions at the ready, and your diamond-encrusted microphones ready at the go, because we've got our resident songbird and our shoulder expert here with us tonight, in Dr.Tania Pizzari. Welcome to Happy Hour.
Thank you, Sean.
So
I forgot my microphone.
I know, we sort of should have got you the diamond-studded microphone. Maybe we can put that into some requests for grants later on.
Yes.
So I just wanted to start with a bit of housekeeping before we start. These sessions generally run for about 45 minutes to an hour. What we'll do is we'll just ask Tania a couple of opening questions, and then we're going to open up the floor to you guys to ask questions for the next half an hour or so. In that, we were asking you to place your questions in the Q&A function in Zoom. So you should see it right next down in your menu below. Please don't put your questions in chat, because unfortunately we can't monitor both and we won't see them. So again, please keep your questions into the Q&A function. You do have the ability to upvote questions that you want to hear the answer to. So if someone else asks a question and you go, yes, I really want to know the answer to that, make sure you upvote it and it becomes higher in our attention. Also, be aware that I might actually come to you to get you to ask your questions. So make sure you have your microphone ready and that question ready, because then you can ask it directly to Tania. The last thing I'll ask is, can we please have no case study presentations? It's always best bang for our buck if you ask generalized questions that are relevant to all of our attendees. So Tan, if academia doesn't work, I reckon I've got a job in breakfast radio based on all these Q&As. So I'm going to ask you a very breakfast radio DJ question.
Okay.
You are deserted on an island. What's the one song or the one record that you have to have with you?
That's an interesting question. Look, my favourite band of all time is Living Colour, which is wasn't a very popular band, but it's definitely my favourite. I'd have to take one of their albums with me.
Are we talking 80s hair rock or a pop band? What are we talking?
It was kind of a rock, soul, almost gospel band. It was 90s, late 80s, early 90s.
And the song that they're known for?
Probably Love Rears Its Ugly Head.
Okay.
Putting that out there.
I can't say I'm familiar with it, but I'll have to take a deep dive on Spotify afterwards and make sure I give it a listen.
Good. If anyone else understands, just let me know.
There might be some closet fans somewhere in our attendees.
That's right.
Now, the other thing is, you do have a fantastic voice. Anyone who's been to the SMA conferences has heard you sing at some point during them. So what we thought we were going to do is we're going to sort of make this a bit of a quiz show. And we're going to ask you whether you could sing a song, but using the words from an abstract of one of your papers. So what we're actually going to do is we're going to start a poll. And hopefully everyone should be able to see the poll. Tania, when you're ready, give us the song.
Okay, I'm going to be a diva. Take my headphones off. Okay. And I'm singing from an abstract of Sarah Warby, who did a fantastic randomized controlled trial on multi-visual instability of the shoulder. And these are the results. Okay. Between group differences show significant effects. They've probably got it now.
Yeah, there was a couple of bit of voting going on before you actually were singing. I thought that might have been a request line, and I would have very much seen you, like to see you sing some Jay-Z. But maybe we'll leave that for a time when we invite you back.
Okay.
Now, all fun and games. That was great and again, I think everyone can give you a virtual round of applause through Zoom. But
thank you.
I think where I want to start with you tonight is whenever I'm a part of a workshop or a PD session on lower limb tendinopathy, the number one question we get is, what about the shoulder? What about the shoulder? Give me something about the shoulder. So I was wondering if you could share with us sort of one tip about the assessment of shoulder, or one thing that you think is vitally important for people to integrate into their clinical practice to help improve patient outcomes.
Yeah. Look, I think probably the most important thing that is sometimes missed, and there seems to have been a period recently where it was kind of thrown out for a little while, and I think it's coming back, which is good, is essentially the scapula and how the scapula is functioning. So how the scapula is moving, how it's sitting at the start of the movement, how it's sitting at the middle of the movement, where it's sitting at the end of the movement, and where it's sitting in functional movements. I think that is really the critical piece to having a good functioning shoulder, and certainly a critical piece for rehabilitation. So yeah, and as I said, I feel like it's potentially for various reasons been neglected recently, but hopefully coming back into vogue a little bit.
So do you think there's a specific reason around why it sort of fell out of vogue? Is it one of those things that's difficult to assess, or is it just not considered?
Yeah, look, I mean, that might be part of it. Certainly, it's difficult to get an objective assessment. So, you can use inclinometers to look at where it's actually sitting. That's difficult through range. It's almost, well, it is impossible to look at from, a biomechanical, 3D biomechanical situation unless you stick pins into bones, which is not helpful, and then it doesn't work because it's moving over skin. So it is difficult to assess, but I think, look, there was probably a few big voices out there on social media in particular that weren't very pro-scapular for a period, and that sort of seemed to infiltrate, as it does these days, seemed to infiltrate the community for a period. And certainly when I was teaching throughout Australia and the world, I got lots of questions about the value of what I was teaching based on the scapular stuff because of particular opinions in social media about it. But yeah, I think it's swinging back a little bit, hopefully, because people see clinically that it's really important to their patients. So I think that's part of it. Maybe a little bit of a combination of that, and then also some of the research showing that potentially, where the scapular position is doesn't necessarily mean that someone will get injured. And, I completely agree with that, but it's, fitting it in with the whole clinical picture. So there's a number of things that were happening, I think, that potentially popped it out of vogue.
So I'll just sort of say to all of our attendees, get your questions in now. We're going to come to you in a second. Just to follow up on that, Tania, do you want to go through some of what you do when you're assessing someone with shoulder pain, and maybe sort of around what you're looking for in terms of scapular position and how that informs your rehabilitation exercises?
Yeah, look, I mean, you can't underemphasize and estimate the value of the subjective assessment, obviously. So in terms of, in particular, how did it happen? Was there a mechanism? Was it insidious type onset? Because that automatically starts to direct you into potentially different physical assessments. The aggravating and easing factors, again, can start to point you into different kind of physical assessments, starts to put those pieces down to your puzzle of your diagnosis. in the physical assessment, it might very much based around your subjective assessment as when you're assessing any joint really, or any. But looking at the scapular position, asymmetry is not a problem, but does it actually contribute to their problem? That's what you're there to assess. Is it that it's downwardly rotated? So majority of us sit at computers most of the time, when we sit with an anterior tilt and a downward rotation. Lots of us are like that, but is it that part of the, so looking at how it's sitting, but as I said before, how it's actually moving, and really importantly with your physical assessment, can you change that? So if you think it's a problem, if you think it's part of their issue, and you can change that and then reassess and make a change to their symptoms, then that's a really important part of where you're going to be directed for their solution, basically.
Yeah, fantastic. So it's sort of always, I think, whenever I hear anything about shoulder and sort of diagnosis and assessment, there are a plethora of different tests, and you only have to do a cursory literature review and you can be, it can sometimes look like just a list of random people's names rather than anything that's really useful. And I know Jeremy Lewis just recently published an editorial about special tests. So I sort of wonder if you could sort of share some of the perspectives from that paper, but also your perspectives on where special tests sit and why we wouldn't potentially use them.
Yeah, sure. Look, I think, when you read Jeremy's stuff, and I have a great relationship with Jeremy, but you talk, there are over 200 special tests, usually named after somebody. So there's lots of names, and it's sometimes hard to remember who did it and what they called it and what it's supposed to be testing. And his beef with them really is that, well, first of all, that there's so many, and secondly, that they're merely a kind of pain provocation tests, which I would agree with, but at the same time, I think there are a number that you definitely still clinically get something out of. So you're not going to throw them out completely, because even though they're pain provocation, they do provoke pain in particular areas, I find, clinically. So maybe it's an anterior structure or a superior structure or a posterior structure, and some of those special tests you kind of get something from. So I'm not doing 200 of them, but certainly, some of the rotator cuff tests, even though they're not definitive, they're not saying this person definitely has a supraspinatus tear, for example, if you do an empty can, full can. But if the person can't hold their arm up and create any force to push up against your hand, in an empty can or a full can position, then it gives you some information. It gives you information about their deficits. And then also it gives you information about what direction you might take for rehabilitation. But then again, importantly, and this comes from a lot of Lynn Watson's work, obviously we work pretty closely together, is that can you correct it? So can you do something to the scapula, put it in a better position? Can you put the humeral head, can you locate it into the glenoid fossa and do that test again? And does it change the outcome? And if it does, again, that sort of directs your solution to that person's problem. If it doesn't, then you're thinking a whole lot of other things. But I think the clinical tests still just add to the picture. So you've got your subjective, you're starting to really, starting to knuckle down as to what it might be. And then your tests, including special tests, might just really reinforce that. So I don't think we can throw them out completely. A lot of them we can, but there's still some, the rotator cuff tests, some of the instability tests, some of the AC joint tests, to try to differentiate what the structures may be involved, I think is still really important clinically. In the research, it might not look so great when you look at sensitivity, specificity, positive, negative, predictive values and likelihood of change ratios, but clinically, I think they're still quite valuable.
Yeah, it's really interesting. It's sort of that goes back to if you can use the test as a sort of symptom provocation and then retest it to help guide your management, it sort of at least gives you a direction. Absolutely. Maybe not a pathoanatomical diagnosis, which I think that's sort of is a nice segue into Hamish Ashton's question. So I'm going to unmute you, Hamish. Hamish, do you want to ask Tania your question?
Yeah, firstly, hi from across the Tasman.
Hi,
Hope you
Hamish.
guys are all doing well. What's your thoughts on clinical diagnosis? The shoulder seems to be going in the direction similar to the back, that let's just call it a dysfunction or whatever, treat some symptoms, where I sort of was brought up a little bit with celiac, saying let's get a diagnosis and treat the diagnosis. What are your thoughts on that?
Yeah, no, look, I agree, Hamish, and I think there's evidence both ways for the back as well. Like I know there's lots of research about just kind of treating the the dysfunction, as you say, but then there's also evidence the other way where you could actually subgroup and potentially get great outcomes to subgroup, and so I'm still in that camp for the shoulder. Like I don't think you can just say, oh, it's subacromial pain syndrome and treat everyone exactly the same and expect to get a good outcome for everyone. It just can't happen. And the research shows us that. So, when you're looking at all the research about how crappy subacromial decompressions are, or, the Cochrane review in 2016 that showed physio and exercise is no better than placebo. The big problem is in those studies is that we're not subgrouping our diagnoses at all. We're just putting all these people in with subacromial pain syndrome or rotator cuff related pain syndrome, whatever you want to call it, the umbrella term, and we're expecting that we can treat them all the same and that they're going to have a good outcome, which is just impossible. So, Hamish, I agree that we need to be better than that, and I think we can be better than that. There's going to be some cases that, potentially we don't have a particular diagnosis for, and, there's going to be other groups that it's might be this and it might be that, but I think we are a little bit better at subgrouping what's actually happening in the shoulder. I think we're going to get better outcomes in our research and also clinically. I think that's really important. Thank you, Hamish.
Yeah, thanks for your question, Hamish. It's sort of, Tan, it's every time we need to go through a systematic review, we sort of say, oh, there's so much heterogeneity in the data, and it sort of probably lends it to the point that you're making in terms of we've got this people with shoulder pain, but who makes up our group and what are the features of them is a little bit difficult to glean from the literature and apply the literature, isn't it?
Yeah, and look, we're perfect example. Rita Kinsella is one of our PhD students at LACEM at the moment, and for her masters, and we're still running it in the background of her PhD, but for her masters did a study looking at subacromial pain and differences exercises, so isometric versus eccentric versus concentric kind of exercises for the condition. And I was one of the assessors to determine whether people were eligible to be in the study. And what we really found was, there was such a broad spectrum. So we were kind of looking at we thought we were looking at with our assessment, we had a whole assessment algorithm. We thought we would get, 60-plus-year-old, predominantly female, grotty cuff type, the typical kind of, shoulder pain, subacromial pain people you think of clinically. But in fact, we had that group, but then we also had this group of predominantly, subacromial pain. They still fit in with the algorithm, but really predominantly caused probably by instability. And then there was people in between, your 40, sort of 50-year-olds who had other things going on. But when we did our assessment based on our algorithm that was, heavily based on what's out there in the literature, they all ticked the box for subacromial pain. And so when we're going to treat these people, should we be treating them all the same? How can we expect that your 70-year-old person with a grotty shoulder and your 25-year-old person with shoulder pain are going to have the same outcome from your rehab? We just really can't. So I think we need to get better at that diagnostic kind of categorization.
Fantastic. Now, I've got to ask this question, if not for me, but it is a question that is coming on a Q&A as well, is the role of imaging. I think it sort of lends it a little bit to Hamish's question in terms of frequently imaging's fantastic at giving us a pathoanatomical diagnosis, and maybe not just one, but multiple. Where's the role of imaging? Does it have a role? Yeah.
Look, I think, clinically, I only request imaging when someone's had a traumatic instability episode. So particularly a young person who's dislocated their shoulder, you want imaging really to see what's the extent of structural pathology, because conservative management often can't overcome that. So I think there's a role in that situation. In a lot of other situations, I think we're probably best not to get imaging, because it can really just build, all those psychosocial sort of elements that come from, knowing that you've got a tear. Like, everyone's got a tear in the supraspinatus when you're 45. Like, it's not part of their problem. So I think unless there's, red flags, obviously, or there's been a significant traumatic incident, or, rehab's really not progressing and you just, you've done your best, then imaging may be appropriate. But I think early imaging is usually quite a problem in trying to manage shoulders then. And everyone's got a bursitis. I always say to my young physios, or even to the patients, great, you've got a bursitis, it means you're alive. Like, if you've got a shoulder pain, you will always have bursitis. You just can't not. It doesn't mean it's causing you pain.
Fantastic. And I've heard you say that a number of times, and it's such a really important thing, because we can sort of say, and I'm sure a lot of people have some perspectives on imaging and might think it's not a lot of benefit, but our patients think it matters, think it's really important. So being able to talk to them and say that bursitis is basically meaning that you're alive can remove a little bit of the fear around of it. So I think that's really important.
Yeah, absolutely.
Amber Bennett had a question. I'll let her ask it for you.
Hi, Amber.
Hi, Tania.
How are you?
Yeah,
long
good.
Time no see.
It has been a long time. I have been trying to kind of piece together answers to this question for a couple months now. But in terms of return to sport testing for contact sports, it seems like a lot of clubs and a lot of sports kind of each have their own protocols, or maybe there's not really a structure at all. And so when you're getting back, other than doing the actual sport, in a graded progressive fashion, are there any key elements that you look for when you're returning someone back to be able to tolerate impact loading or that long lever?
Sorry, is Amber cutting everyone or just me?
I think she just, we lost her at the end. But yeah, if you want to start with her question.
Yeah, sure. This is where we need Andrea. Where's Andrea? No, it's a great question, Amber. I think you're absolutely right in that the protocols vary so much, and no one has the absolute and really a good idea about what it means, whether it should be time-based or sort of function-based. Obviously, the surgeons, are often very time-based. And if you look even at something like ACL, like, it's only now that we have some more robust kind of measures to be able to test whether someone's ready to go back. I think for the shoulder, for me, they need to have, being able to participate in kind of full track, but really importantly with no apprehension. I think that's probably the critical thing, so that, particularly for instability. So, you need to be able to get up off the ground, you need to be able to fall on your shoulder, you need to be able to tackle someone if it's a contact type sport. So you've done all that sort of stuff in training, but you haven't been apprehensive about doing it. And so that's probably one of the critical things for me before I'm happy to let someone go back, particularly to Australian football or rugby, where tackling is, and being tackled, actually tackling is probably the critical thing where they're likely to sort of re-injure. So if they're happy to do that and they're happy to do it multiple times and when they're fatigued, then, I think that's the critical point when they should be able to return. And look, for other sports, it's really, it comes down to more, their range of motion, their stability at the end of range, and again, just their confidence and their performance. So are they, if it's a tennis player, are they serve, back to what they're previously able to do in terms of speed? I just rehabbed a dodgeball player, the captain of the Australian dodgeball team. So, is he able to throw 200 throws in a dodgeball game and not be too sore afterwards, and not be apprehensive about doing it and not landing and those kind of things. So hopefully that answers your question, Angela.
Brilliant. So I think that sort of lends nicely in terms of, especially with you talking about making sure that they can return to sport with apprehension, and pain sometimes being a little bit of an indicator, but pain during exercise. So you've given your athlete or your patient exercises, they have pain during those exercises. What's your feeling on that? Do you just educate them about that it's going to be painful, or do you reduce the intensity or something around the exercise to make sure that it's painful?
So that's a really good question, Sean. And I know people have different opinions on this, and I'll just say from the outset, this is my opinion. Like upper limb conditions and joint conditions have a much higher propensity to central sensitization. And when you compare that with something like an Achilles tendinopathy or a patella tendinopathy, and I know I've heard Ebony Rio speak about this, and maybe something to do with the continual sort of use of your upper limb. So you can't kind of get away, even when you're talking, you can't kind of get away with not using your upper limbs, whereas you can get away with occasionally not using your lower limbs or not stressing the tendons, for example, if it's a tendinopathy type condition. So there's sort of a break from pain when you're thinking about lower limbs sometimes. When you've got the upper limb, there's this constant pain, and they are, for whatever reason, more susceptible to central sensitization. And so when I'm exercising, I am concerned with pain. So I don't want people to feel really any pain when they're doing it. If it's a tendon condition, if it's a degenerative tendon condition, they're feeling pain while they're doing it, they're going to be in a lot of pain after they've done it as well. And if it's an instability type patient on the other end of the spectrum, if they're feeling pain when they're doing it, they're often in the wrong position. So the humeral head is not located in the glenoid fossa, the scapula's in a poor position, and the rotator cuff are being overworked when you're trying to actually do the exercise. So particularly in the early stages, I'm not a fan of pain. But the critical thing is to teach the patient what you mean by pain, because sometimes they're in pain, but it's just because the muscle's working. So, and that's a very different thing. So if they're feeling like a burning in their external rotators when you're doing external rotation exercise, that's fine. But if they're feeling their biceps tendon pain when they're doing it, that's not so good. They're often in the wrong position. So as I said, particularly in the early stages, zero pain, unless it's that muscle pain that they're feeling the muscle working. And so many people just really misinterpret what they're feeling. And that's a really important conversation early on. In the later stages, I'm still actually not that happy for them to be experiencing their pain. That pain that they had before they had their surgery, or that pain that they had, that was the thing that they came in with. If it's something different, that's okay. But if it's their pain, I'm not happy with it, because it means to me that they're kind of overstressing whatever structure they've been overstressing. That's just my opinion.
Yeah, I suppose it's one of those really difficult things about we don't often look at their pain during exercises in research, so it's sort of difficult to learn, and it's great to get your clinical perspective. So then it sort of, I think, also leads on nicely, then using pain to sort of see whether you've got the loads right or the exercises, rehabilitation exercises right. Do you use pain or some other marker to know when to progress your patients?
Yep, that's a great question too. Again, it probably goes back to Hamish and the subgrouping, but I think if you're looking at sort of a degenerative tendinopathy type patient, they often feel pain later on, and you guys know that with the tendon stuff. So that night pain is a really critical thing, and so you get people to monitor that. So if they have an increase in night pain, or if their night pain's more than, say, a 3 out of 10, then you're not progressing them with a tendinopathy. If it's an instability type patient, then you're progressing based on stability. So you're progressing based on the fact that they can maintain good scapular position, or they can hold their humeral head well in the glenoid when they're doing the exercise, and they don't lose that over 20 repetitions, for example. So they can do it in a sustained fashion, and then you're ready to up the ante. They might still be doing those other ones in the background, but you can progress the range of motion. So you might start to, do their rotators up into abduction, but it's really about stability. And that, look, it's not only just for stability patients, but all of your shoulder patients. Look at people's form when they're doing it and see that they can maintain the form through the whole exercise, and that's when you can progress them. So when you can get to 20 repetitions, 3 sets, maintaining your form, controlling where the humeral head is, then I'm happy to progress that exercise, make it harder, make it faster, make it through range more, bring it into abduction, and only then really that you'd be concerned about that. And so it's not necessarily pain with the shoulder, it's much more about control.
Fantastic. Well, I have just seen a late surprise guest, which I'm very excited to see, because we have been getting a lot of questions. So, Andrea, thank you so much for jumping on at this point. We really appreciate it.
Thank you, Sean. Yeah, sitting here at an emergency, it's a little odd to be speaking to people about shoulder injuries, but all good.
What better place, Andrea?
Exactly. You might be able to give some advice to other people in the ED just by them overhearing. Now, for those who don't realise this, we've got Dr. Andrea Mosler, who is another postdoctoral researcher at our research centre, and has worked with a lot of overhead throwing athletes. And Andrea, we've had a couple of questions about this. So in sort of 1 or 2 important points, what are some of the important rehab aspects when you're trying to rehabilitating an overhead throwing athlete?
Yeah, look, I think one of the key things when rehabilitating an overhead athlete is, first of all, working out exactly the loads of their specific sport. So that will be really different in a cricket thrower versus a baseball pitcher versus a water polo player. And also it will depend a little bit on the presentation of the shoulder. So in particular with a water polo player, for example, we need to really be careful to build up their tolerance to the different loads required of that sport. So part of it might be building up their tolerance to swimming, building up their tolerance to throwing, building up their tolerance to shooting, and also being safe with the contact and the weight training that's required for that sort of sport. So those different phases may actually occur at different points within the rehabilitation. So that's actually almost the art of the rehabilitation of the overhead shoulder in athletes.
And one of the things that sort of Tania was talking about before was about them setting them back into sport when they're not apprehensive, being one of the components, but also she spoke about her tolerance for pain during the rehabilitative exercises. Is that any different in the overhead athlete? Are you tolerating them having more, a little bit more pain when they're back to their sport, or are you sort of trying to get them back to a pretty low and stable level?
Oh, look, that is so difficult because because every athlete will almost have a different ability to tolerate pain, and you probably need to look at that more at an individual level. They've done surveys looking at, say, elite male gymnasts, and up to 95, 90, 97% of them experience pain in most trainings. So it's normal for them to experience pain. And you may have an overhead athlete who really feels like their performance is particularly affected when they have to experience pain while they're throwing, while you have other throwing athletes that can tolerate a 4 or 5 out of 10, and that's normal for them. So my feeling is that it's probably a panacea to try to expect to be able to rehabilitate and and have overhead athletes return to sport without any pain whatsoever. But I would use a similar kind of traffic light system that we use with a lot of other injuries in overhead athletes. So over 6 out of 10 is pain that we can't tolerate. Between 4 and 6 will probably be something that we would negotiate with the athlete, and under 4 is probably able to be tolerated.
Fantastic. Tam, anything to add?
No, that's fantastic, Andrea. That's awesome.
Brilliant. So we're getting towards the end here, and we did have one question from an anonymous attendee. And this is probably for both Andrea and Tania. Are there any sort of shoulder exercises that we could consider to try and prevent shoulder injuries? And I suppose in both our daily population as well as our athletic population.
Well, I think in the athletic population, I'm sure Andrea will add to this, that there's a little bit of evidence to show that, some rotator cuff strengthening, and in particular, so proprioceptive type strengthening, using weight-bearing type exercises can help to prevent rotator cuff or actually instability episodes, and that was in a rugby population. I think in the general population, there's so many factors that impact on the shoulder, and not, probably most importantly, lifestyle type factors. So, don't get diabetes, don't smoke, have a healthy lifestyle, and that will protect your shoulders. But I think in terms of, I think having good external rotator strength, some good scapular position, good posture, also helpful for preventing shoulder problems in the community. Good thoracic mobility, so people working at computers all the time, not putting their shoulders under stress. So yeah, there are lots of prevention, but I don't know whether we could do it population wide and wide and get any great result. But I'll let Andrea comment on the sporting.
Yeah, Andrea, for the athletic population, is there any exercises or anything that research can tell us about preventing shoulder injuries?
Yeah, there's a little bit of contradictory evidence about risk factors for shoulder pain in overhead athletes. But certainly from my clinical experience, ensuring that they have optimal external rotation strength relative to their body weight, but also the ratio between internal rotation and external rotation strength. And we want that ideally for the throwing athletes to be under 1.5. So we don't want the internal rotation strength to be too much greater than the external rotation strength. As Tania mentioned, there is some evidence with that dyskinesia can be a risk factor for developing shoulder pain in handball players, but then in a relatively similar population, but males and females, reproduction of that study actually found that scapular dyskinesis was not a risk factor for overhead shoulder pain. So we don't have strong evidence of scapular dyskinesis, but it makes sense to ensure that we have good scapular strength, good strength of the scapular muscles and control. And most importantly with our overhead throwers is to look at their biomechanics and ensure that they're optimally using their kinetic chain. And this is something that we had a lot of challenge with the water polo players because they're basically trying to throw in water. So trying to ensure that the forces imparted onto the ball come more from the lower limbs and the trunk. And totally agree with Tania that having optimal thoracic rotation and lateral flexion is really important for ensuring that kinetic chain linkage is optimal.
There's some fantastic clinical perspectives. I'm sure everyone's finding them really useful. Tan, just to finish up, you've spoken a number of times about educating your patients, communicating, and one of the attendees asked a question is, how important is self-efficacy in managing someone with shoulder pain? And then how does education potentially play into that?
Yeah, look, I think self-efficacy, as we all know as clinicians, is critical in any injury. So if a person believes that they can overcome the condition or get back to their sport or get back to work, then generally they will. That's the key ingredient. So education is critical. If you can get to them first before they've had scans or injections or a surgical review, then I think they generally have a really good outcome, because we can educate them that, yes, you have this shoulder pain, but we're going to do this progressive kind of exercise program, get your shoulder strong enough to withstand or to increase capacity for whatever you need to do in your work or in your sporting activities. And so that's fine. But, if they've already got some beliefs that either, then other people have put into their heads or that they've read on Google, then that can be a little bit more of a challenge. But so education really is critical, and particularly for conditions that are just going to take a little while and you just need to stick with them. And that's probably something that I see sometimes physios or practitioners do wrong, is that they just really try and progress people because they're not quite sure what else to do, rather than say, look, this is going to take a little bit of time, and really educate the patient on how long it's going to take, and that they have to progress slowly what the condition is, and just keep them actually with it. So education is really critical. And I find, if you can give people some prognosis, if you understand the condition well enough, then people really feed off that, and they really increases their self-efficacy.
Brilliant. I think there's some great research by Rachel Chester in the UK, where she's looked at sort of basically the biggest predictors of positive outcomes for physiotherapy is, one, their level of self-efficacy, and also if they thought they were going to get better from physiotherapy. If they thought they were going to get better, they got better. It's sort of surprise, surprise. So that education and all those sorts of things that indirectly can affect that are just so important, aren't they?
Yeah, absolutely. And Rachel's stuff also showed, that the detrimental impact on that, they have a surgical review, and then the person and the surgeon says, look, go and try physio. And if that doesn't work, then come back and we can operate. So, it's that whole idea that I don't really think that physio is going to work, but I can fix you. So why would somebody want to do for 3 months and have physio when they think that the person telling them that has the answers to their problem? So yeah, I mean, we talk about this all the time, but education and the way that the language that you use, and they're all critical. And I don't know if they're more critical in shoulder, but they're still critical. So
still something that sort of needs to be considered.
Absolutely.
Tan, your vocal cords are probably straining by the end of this. So
what do you want me to do now?
I was going to say, we won't finish up with a national anthem or anything like that, which you have been known to do at certain basketball tournaments. But just to finish up, for the attendees that have listened to your fantastic answers tonight, what's the 1 or 2 hot tips that you hope they take away from tonight?
Hopefully that the scapula was and always will be important in terms of shoulder function. Well, potentially, listening to me and Andrea, that that we've got a long way to go, I suppose, in terms of catching up into shoulder research and return to sport and criteria and things like that. But we're doing our best. And that also, I think we do need to get better clinically, but also from a research perspective about those subgroups. And I think that will change the way we manage and the patients and get better outcomes in our research trials and in the clinic as well.
Fantastic. Well, thank you all to our attendees and our fantastic panel members. Thank you, Tania, and thank you, Andrea, for logging in from the emergency department.
Thanks, Andrea.
Brilliant. Again, thank you to all the attendees who were on tonight. We really are thoroughly blown away by the responses these have had, and we are going to continue to do as many of these as we can. If you can, it is worthwhile you bookmarking our blog, which you should be able to find through our Twitter page, our Facebook, because we do post the recordings of these videos on the blog and through SoundCloud and YouTube. So you can get it wherever you want to get your PD content. Meg, you have posted the blog's website in the chat. That's fantastic. Make sure you bookmark that website. It's always a great resource for fantastic infographics, as well as follow-up reports from sessions like this. Upon closing the event, you will be taken to a survey. It'd be great if you could spend 30 seconds completing that, because it's really useful for us to try and make sure that we're creating events that are best suited to your needs and that you find enjoyable. So again, thank you for tuning in tonight. Keep engaged with our social media channels, because that's when you'll hear about our next webinar, and Q&A session, which will let you know when that happens as soon as possible. So again, thank you, and have a good night, morning, day, wherever you are. Thanks.